In renal failure, metabolic acidosis is most expected. This occurs because the kidneys fail to excrete hydrogen ions, leading to an accumulation of acid in the body. Understanding this imbalance is crucial for managing patients with renal issues. Partial compensation in ABG findings is confirmed when the pH is abnormal, and both components are abnormal in opposite directions. This indicates that the body is attempting to correct the imbalance, but the pH has not yet normalized. A patient with chronic alcoholism and severe diarrhea is likely to experience metabolic acidosis. The loss of bicarbonate and diarrhea leads to this condition, highlighting the importance of monitoring acid-base balance in such patients. For metabolic alkalosis secondary to diuretic therapy, monitoring potassium levels and replacing them as needed is crucial. Diuretics can cause hypokalemia, which worsens alkalosis, making this intervention a priority. ABG values indicating partially compensated respiratory acidosis show a low pH, high PaCO2, and high HCO3. This suggests that the body is attempting to compensate for the respiratory acidosis, but full compensation has not been achieved. In a patient with Guillain-Barré syndrome who is hypoventilating, respiratory acidosis is anticipated. Hypoventilation leads to CO2 retention, causing an acid-base imbalance that requires careful monitoring and management. Tetany is the most concerning symptom in a patient with respiratory alkalosis. Low CO2 levels lead to hypocalcemia, which can cause tetany, emphasizing the need for prompt intervention to correct the alkalosis. In a patient with severe infection developing lactic acidosis, ABG results would show metabolic acidosis. The buildup of lactic acid causes a decrease in pH, requiring immediate attention to address the underlying infection and acid-base imbalance. A scenario reflecting mixed acidosis involves COPD with pneumonia exacerbation. COPD causes respiratory acidosis, while pneumonia adds metabolic acidosis, necessitating comprehensive management of both conditions. Full compensation in ABG results is indicated by a normal pH with abnormal PaCO2 and HCO3. This suggests that the body has successfully compensated for the acid-base imbalance, achieving homeostasis. A patient with a pH of 7.55, PaCO2 of 28, and HCO3 of 24 is likely experiencing respiratory alkalosis from hyperventilation. The low PaCO2 with high pH confirms this diagnosis, requiring interventions to address the hyperventilation. In metabolic acidosis from renal failure, administering IV sodium bicarbonate is a priority intervention. Severe acidosis may require bicarbonate therapy to correct the pH imbalance and stabilize the patient. A patient with cirrhosis developing hyperventilation is most likely to experience respiratory alkalosis. Hyperventilation lowers PaCO2, leading to this condition, which requires careful monitoring and management. A trauma patient with a pH of 7.1, PaCO2 of 30, and HCO3 of 12 is experiencing partially compensated metabolic acidosis. The low pH and HCO3 with low PaCO2 indicate respiratory compensation for the acidosis. For a patient on mechanical ventilation with high ABG values, decreasing the ventilator rate is anticipated. A high rate leads to CO2 loss, causing respiratory alkalosis, which can be corrected by adjusting the ventilator settings. A patient with COPD and ABG results showing low pH, high PaCO2, and normal HCO3 is experiencing uncompensated respiratory acidosis. This condition requires interventions to improve ventilation and correct the acid-base imbalance. A patient receiving NG suction with high pH and HCO3 is experiencing metabolic alkalosis. The loss of gastric acid leads to this condition, necessitating interventions to restore acid-base balance. In a patient with sepsis and ABG results indicating low pH and HCO3, metabolic acidosis with partial compensation is likely. This condition requires addressing the underlying sepsis and supporting the body's compensatory mechanisms. A patient with vomiting for 3 days showing high pH and HCO3 is likely experiencing metabolic alkalosis. The loss of gastric acid leads to this condition, requiring interventions to restore electrolyte balance and address the underlying cause. A patient with hyperventilation from salicylate toxicity will initially present with respiratory alkalosis. Early salicylate toxicity causes hyperventilation, leading to this condition, which requires prompt intervention to prevent further complications.